Is that the menu?
Yes. I don't really know.
Total case 164. No. The CDC is very late in posting. They're really doing a bad
When you
job.
look at John Hopkins, it's about 3
Oh,
times.
I
Yeah,
know.
Hopkins
That would
is,
not be good.
and they're spot on.
I mean, when
When
I
you look
looked
back
at it,
at what they said 3 days ago, they're saying really.
Well, we'll see how it goes, but, you can talk and then if not,
Well, I had not intended to. All right.
but we can.
Who's that guy in the middle of the second round?
Oh, over here.
So this
He's on our board now.
is the stuff that you and I were in.
Tom, we had a sheet for you.
Is she on board with it, or are you both going to say?
Yes.
She's gonna do the introduction and then click the mute
Okay.
and then ask her questions.
Is that the picture you want?
I guess, that,
That must be your favorite picture.
It's one of my favorite
this is mostly just in response to questions unless.
Well, I just, I don't want to spend a long time.
We have a seat for you up here, Tom.
Seriously or no?
Yes.
Are you going to object if I start my remarks as we consider the duties of public health officers in events of this nature? Chill the rhetoric. Or words to that effect.
I think that's probably okay.
Say it's off the record.
They've been fairly judicious locally so far.
Well, yeah, I don't read the slime and I don't get the TVC. I get the cigarette and stuff. They've been fucking bad.
Yeah, most of the history is on that national media.
Okay.
And that's actually the opening. Okay, questions about that. Good morning. Good morning. Yeah, I just want to double check this before I say it. You don't have any cases. That's good. We have no cases.
As far as I know, there are none in QC. Probably better way to say it.
Okay.
The only 3 are those in Johnson.
Okay.
If not, we can share others.
Identity cats. Yes.
I think everybody's here, so we're ready. Start.
Not quite 9:30.
CDC hasn't
A late arrival might be
Okay.
trying to get through the door.
the blood supply. And at the end, they said, now let me put on this hospital and public health. When you guys can send the airborne fit tested and notified respirator.
Oh, okay, yeah.
Because nobody's got equipment.
Home video over.
Anybody.
It was turning on the right. So like, no.
I've done that. I have done that.
Just
You want it horizontal?
couldn't.
That's the way it generally goes.
No, I think it's supposed to be upright for Facebook Live.
So you
Otherwise,
did
it's
that.
crooked when you post it
But
on.
it really puts you in a box.
Oh, I never thought about that.
Yeah.
Everyone's
I've done that too. So
You learn
done
that.
the mistakes. Yes.
Well, you do what you can do. That's all you do.
I didn't mean to.
That's a cute hair. I was at Walmart, tipped and probably 25% of the people were there.
Yeah, I would.
Good morning. It's 9:30, so we'll go ahead and get started. Welcome and thank you all for coming today. The Quad Cities area does not have any reported cases of COVID-19 at this time. I just wanted to make that clear at the beginning here. We are following all the guidance from our state and federal partners. Healthcare partners from both sides of the river have met to talk over the preparedness efforts, and we continue to closely monitor the situation as it unfolds. At this time, I would like to turn it over to Dr. Louis Katz. He's the Chief Medical Officer for the Mississippi Valley Regional Blood Center, and he's an infectious disease specialist. And after his remarks, our panel here from both healthcare systems and both health departments will answer any questions you might have for us. Thank you.
The picture on the screen is on purpose. And if this ruins anybody's breakfast, I don't care. I'm actually here because I'm medical director at the health department. That said, we want everybody to come and donate blood at the blood center. So if that's a conflict of interest or self-serving, so be it. So this epidemic is with the coronavirus. There are 7 that infect humans. 4 of them we've known about since as early as the 1960s. They cause colds. There are 3 that have appeared since 2003, SARS, severe acute respiratory syndrome, MERS, Middle East respiratory syndrome, and now the new one, I'm calling it SARS-2 to keep it short. That's the name of the virus. COVID-19, coronavirus disease, is the name of the disease. So the virus has a name given by one group, and the disease, the illness it causes, has a name given by another group. Someday they'll probably sit down and figure out an approach, a unified approach. So this is a third important bad coronavirus that we've seen emerge in less than 20 years. I'm asked consistently, how bad is it compared to the other 2 bad ones? And the comparisons are not apt. They're each distinct, and we probably should just give up on comparing how serious they are as clinical illnesses, and I'll mention a little bit of that a little later. They're all believed to be zoonotic. Zoonotic means they came from an animal reservoir and jumped into humans. In the case of SARS, from bats to palm civets to humans in China. In the case of MERS, probably from bats to camels to humans in the Middle East. And in the case of the new virus, probably from bats to an unknown intermediate host to humans, maybe in wild animal markets in China, maybe not, where that hasn't been nailed down to my satisfaction at any rate. See if I can make this change. I'm working off of notes here, and I don't know how to work this thing. I don't usually work from notes. There we go. So coronaviruses are these enormous RNA viruses. They are lipid enveloped, and I only bring that up because that's important. Lipid envelope viruses are weans. They're wimps. They are easily inactivated, and in the case of this virus, by virtually all of the standard household disinfectants. That fatty envelope around the virus is quite easily disrupted by things like soap and alcohol and a whole wide variety. So that's important for people to understand. It is easy to kill the virus in the environment. If you don't do anything, it can last for quite some time in the environment, but it dies very quickly with essentially any of the over-the-counter household disinfectants. Looks like a bat coronavirus, much more closely related to some bat coronaviruses in China than the SARS coronavirus. So it's a little bit unfortunate that it's picked up the name SARS coronavirus 2019 or 2 or whatever we're going to call it. The spread is presumed to be by droplets, and that's based on good epidemiology from China. The way it spreads is consistent with droplets. It's based on precedent of all the other coronaviruses that spread by droplets. That's why I show you this. Droplets are the big chunks. So if I cough into your face and you feel that wet stuff hit your face, those are droplets. This is distinct from classic airborne transmission that is seen with measles and tuberculosis, for example. Measles and tuberculosis are true airborne as opposed to airborne droplet. Measles and TB stay suspended in the air of a room where a patient has been for hours. So if a kid comes into your pediatrician's office with measles and somebody else comes in an hour and a half later who is not immune, they are very probably going to get measles. These big chunks settle out of the air within minutes. Within minutes. They do contaminate the environment, but this is not something where if somebody in the back of the room coughs now who has the virus, I'm going to get it here if we're here for another half hour, 45 minutes. This is very important. It informs the way we deal with the virus as the epidemic evolves. And so I want you to pay attention to that sort of distinction. I don't know how to make this work anymore. I have broken it. Well, if I can get my next slide up. Yeah, so the case summary to date, and this I updated this from the Johns Hopkins CSSE website, Johns Hopkins University CSSE. That's where you go for the most recent case counts. Certainly with regards to the cases identified in the United States, the CDC's website looks to me to be 24 to 48 hours behind. And the most current and very credible case counts you can get at the Hopkins website. So if you're looking for that information, that kind of information, go there. CDC has some nice U.S. maps that Hopkins doesn't have, but I think the best resource for what's happening globally with the outbreak is Hopkins. So 110,700 cases as of this morning, 3,800 deaths, and about 62,000 patients who have been confirmed infected have fully recovered. So those are the kinds of numbers that we're looking at. By contrast, there have probably been 16 million flu cases in the U.S. this flu season, and between 10 and 20,000 deaths. 10 and 20,000 deaths from influenza. Okay, so it's context that this isn't the only thing out there that's bad. We diagnose it with a test called nucleic acid amplification. Detects the genetic material of the virus. Very sensitive, very specific, very good. It has a major drawback, and that is it tells you if somebody's infected at the time that you take the sample, but it doesn't give us a picture in any way, shape, or form of who has been infected. So if you have a symptomatic person with a positive nucleic acid test, PCR is the common assay, polymerase chain reaction, you can tell they're infected now. But if there are people who aren't coming into care, either they're not sick, they're asymptomatic, or they're not yet symptomatic, but they're infected and potentially capable of spreading it. We don't know that. And we won't know that for months until we get a test based on the body's immune response, an antibody test or a serology test. And the importance of that is as you're reading all these numbers that are showing up in the media about case fatality rates, infection fatality rates, those sorts of things, they're not accurate yet because we don't know who's infected. The only people we know are infected are the people who get sick, show up for care, get tested, and have a positive test. It almost certainly very extensively underestimates how many infections there are. And when your denominator of how many infections there are is too small, which I think it is, then the fatality rates look higher. The sickest people get diagnosed, the sickest people die. So as you're looking at all these statistics that are showing up in a variety of media sources, be extremely cautious. We don't have a good way to measure how much infection is occurring that we're not finding. Does that make sense? Is there anybody in the media that doesn't understand this? It's really critical for context of how serious this is or is going to be as time goes on.
Is that true for China as well?
Probably, almost certainly. Yeah, we just don't know the burden of asymptomatic cases or cases that never came into the system to be cared for. And we won't know that until we have a really good antibody test. Very hard to develop. They're very difficult to develop. We have a very good antibody test, and we can do population-based surveys and find out who got infected. Months, almost certainly months away from good data on that, what's called the denominator. Okay? Really important for you guys to have that context as you report. So that's the big chunks. What we saw in China, and I think the surveillance in China is credible at this point. I think they've done a good job. The patterns, the trends that have been identified are probably good. Whether the absolute numbers are right is an interesting question, and again, we'll know that months down the line. Their epidemic peaked the last week of January. Their peak number of cases was the last week of January. Over the last 14 days, there have been more cases outside China than in China. And over the past 2 to 3 days, there have been 100 or fewer cases recognized in China. Over 80,000 cases in aggregate in China, and 100 a day or so over recent days. So it looks as if the epidemic is over in China, and we don't know why. One presumes it has something to do with the draconian measures that we're taking, closing down cities of 1 million, up to 11 million, confining people to their homes, closing businesses, all the things that they've done, surveilling electronically, things that it's interesting to discuss whether we can do them here. Okay? That may be part of it, but there's an enormous amount of biology of the virus we don't understand. We assume that everybody in the population is susceptible to a new virus. It may be true that anybody in the population can get sick, it can get infected. But infected and sick are two different things. It may be that there are determinants, genetic or other determinants in people that say, yeah, you'll get infected, but you won't get sick, right? So the point here is not that we know what's going on, it's how much we don't know. It is very reassuring that the epidemic appears to be waning in China. Whether it's going to come back in subsequent waves like influenza pandemics can, or if it's going to be gone when it's gone, is something, you know, you ask me in June, I might know the answer, or July. The cases, the peak age for cases, people who are sick and diagnosed, is in the 50s and 60s. The peak death rates are in the 70s and 80s. Well, that makes good sense. That's just like flu. When you're old, like, for example, my boss, not to say me, you have comorbidities, you're older, you're less capable of fending off things that a younger, healthier person is able to. So peaks in mid to late adulthood, but the morbidity, the mortality peak in older age groups. There is this sense that it's not infecting kids, and I'll bet anybody here a bottle of their favorite wine, that is not the case. The kids are being infected, but they don't get sick, so they don't get picked up in surveillance. And there are a large number of viruses that behave that way. Common monoviruses, for example, cause almost no illness in a toddler or a grade school kid, even up as they approach high school, but make adults very sick. And this has to do with complicated interactions with the immune system, where the immune system actually causes a lot of the signs and symptoms that occur when somebody gets sick from an infection. So I think we'll find out that these young kids are in fact being infected. Their role in spreading the infection is totally unknown at this point. So this is, once again, to tell you what we don't know. 80% of the cases are mild. This is data from 50,000 cases in China. 80% are mild. That means essentially they look like they got a cold. 14% are severe, which means they're presenting with pneumonia, and only 5% are critical. Those are the people that wind up in an ICU on a ventilator, and some of them die. Okay? 80% of the cases in China have been mild. We'll continue to evolve those numbers as time goes on, but that's what we know, that's what we think at this point. So we're estimating, and I've told you that I think it's an overestimate, a 2 to 3% case fatality rate now. The early numbers coming out say 2 to 3% of the people who get sick die. In contrast, very good numbers on MERS and SARS are available. Those outbreaks have been, they're mature outbreaks or gone in the case of SARS. And so we really have a very good idea what happened with them. 10% of SARS patients died. 35% of MERS patients die. Okay? We're talking about a 2 to 3% mortality rate that I think is a little high. On the other hand, there are many, many more cases of the new virus, of COVID, than there were of SARS, about 8,000 cases of SARS, or MERS-CoV. So even a mortality of 1 or 2% is going to be a lot of premature death. So it's incredibly serious, but in context may not be as lethal a pathogen as the others. Incubation period, the time from you get exposed until you get sick, is in the 5 to 6 day range and goes out to about 13 days. That's called the incubation period. And that's important. 13 days, 12 and a half, 13 days appears to be the maximum. That's where that 14-day quarantine or self-isolation comes from. So if somebody has been exposed or you think they've been exposed and you have them self-isolate or they're in quarantine for 14 days and they haven't gotten sick, they're not going to get sick. That's where 14 days comes from. It's not like a made-up number. One of the things that's going to complicate how we respond in the U.S. as sustained community spread begins to occur, and it's going to. It's already happening in Washington State. So it's not going to go away. We're going to have sustained community spread. The question is how much. And guess what? We don't know. But there are at least 3 family clusters that I'm aware of that document very nicely that people are transmitting before they get sick. Okay? So just saying if you've got a cough, stay home is not going to stop the epidemic, the pandemic. All due respect to WHO. Look up the definition of pandemic. This is a pandemic. It's in over 100 countries. And so that was an editorial comment that was probably inappropriate. But we know that transmission is occurring before people get symptoms. So depending on the level of community transmission that is being seen, we're going to need to do more or less draconian things. And so you start talking about school closures, business closures, university closures, work from home, on all those things that get people apart. Not so much to reduce the ultimate number of people who get infected, but to lower the peak and extend the epidemic so that our health care and social services can be maintained without crashing. And that's really at the point that we start seeing sustained community spread, that is, spread from person to person that's outside of a recognized transmission chain, then we're going to have to take measures. I suspect we're going to have to take measures of the nature of what was seen in China, but I'm pretty sure we can't be as aggressive as they were in China. I don't think it's going to be possible to effectively lock down entire metropolitan areas. We'll see. I could be wrong. The rate of asymptomatic or pre-symptomatic infection, we don't know. Okay? Some of the small case series from China suggested it was pretty uncommon, but the most sobering data that I've read over the last several weeks is the work that was done on the Diamond Princess. There were 3,700 passengers and crew. They did 3,000 PCR tests on passengers and crew. 619 had confirmed infection. Half of those people had no symptoms at the time that the viral genetic material was found in their samples. As you've probably heard, the ability to do good epidemiology on the boat was not ideal, so we don't know if they had symptoms before or developed symptoms after. So worst case is that a lot of people have no symptoms and may be able to transmit the virus. And if that's the case, we're in for a bad epidemic. Okay? We know how to deal with things that are transmitted by the droplet route. In acute healthcare, which is not in the community, it's different. Acute healthcare is different. You are clustering people that actually have what you're looking for. So there we'll use very tried and true barrier precautions according to the recommendations of various expert organizations. In the general public, it's really about common sense. Things like don't go out when you're sick, cover your cough, wash your hands, social distancing, simple social distancing measures. I want to stop now, and we can start taking questions. Questions?
You were talking about precautions, this whole area could take, if this gets to a certain point, the school closings, business closings. Is there any way you can say how close we are to that happening?
No. There are 6 cases in Cook County, Illinois. None of them look like, in any way, like sustained community transmission. There are 3 presumptively confirmed cases in Johnson County. All appear attributable to that chain of transmission on the Nile cruise in Egypt. So we're just not there yet. On the other hand, there's clearly sustained community transmission in the Pacific Northwest and probably in California. And it looks to me like there's some being established as well on the eastern seaboard. My assumption is it's going to happen here because I think in public health you get paid to think about what's the worst that can happen. Predicting what's going to happen is a fool's game, but I think we need to be prepared for sustained community transmission. We need to look at the pandemic plans that we all wrote in 2009. They will work very nicely with virtually no modification for this virus. And we need to be planning. We need to know how we're going to manage in acute care when masks are on back order and begin to run out. We need to know at what point we need to look at things like closing schools or businesses if we think that that's where transmission is occurring. And we're going to do this on the fly from the level of WHO on down. This is really on the fly at this point. And it's about doing what you can do the best you can do with the resources that are available. 80% of the masks that we would use in this outbreak are manufactured in China, for example. What happens when Dr. Matwani runs out of masks at Genesis? What do? Those things have to be planned for and thought about. You have to think about, there's a place that I have worked in the past where, in point of fact, somewhere between 20 and 30% of the employees have burned all their sick leave. They have no sick leave. So when I tell them you have to stay home when you're sick, then how do they buy groceries and pay the rent? So you have to look at your HR policy. I mean, details of that nature need to be thought about, and there are hundreds of them. That's why we have pandemic plans and checklists So I have no predictions. Lisa has
The
predictions.
pandemic plan that you're talking about, is that the CDC's pandemic plan, your pandemic plan?
Aggressively not. This is the planning that we all had to do in our various venues in 2009. So the health department has a plan. The hospitals each have a plan. The first responders have their plan. Our blood center has a plan. Businesses have plans. And they're particular to the circumstances of the environment that you're working in. It's not magic. There are all kinds of tools at the CDC website for developing plans. And so if you don't have a plan, you need to get one. Borrow one from somebody that has the same kind of business that you have if you didn't do it in 2009. Under about this much dust, somewhere on the shelf at most places, is that plan from 2009. You have to open it up, review it, exercise it, implement it. And it isn't the plan. It's having thought ahead far enough to do a plan. There will always be a new twist that the plan didn't directly address. But having thought about it up front is the critical issue.
So your message today is for leadership or general public, or both?
Both.
Yeah.
Yeah, the general public, there's a billion messages coming
Right.
about staying home when you're sick, cover your cough, wash your hands. It's not sexy. It's not high tech. Pay attention. That's the stuff that works. That's the stuff that works. There was a plane that flew from Wuhan in China to Germany with 126 people on it. 16 of them were either contacts of somebody with COVID or had symptoms of COVID. They were in Wuhan. Not one of them had a positive PCR at screening when they debarked in Germany. The only two positive PCRs were two people out of those 126 who were completely well. So we need to think in those terms. We need to think not just about who went on the Diamond Princess or who's just back from China. We need to think about basic manners. Cover your cough, wash your hands, stay home when you're sick. That's the general public message at this point.
And what about people who just go out and buy masks and wear them all the time?
Well, there's absolutely no evidence that a well person is significantly protected by wearing a mask, despite a lot of people wearing masks. The thing that it does, it diverts masks that are going to be needed in acute care if the epidemic gets bad. So you don't see me wearing a mask. Well, some people think this must be a mask, but I think that I will fail at convincing some segment of the public that they shouldn't be wearing masks, because those masks need to be made available to the hospitals and the clinics and the acute care facilities and the first responders. But they're at much higher risk than the general public. Remember, you're 80,000 cases in China. How many people are there in China? 2 billion? 3? How many? Billions. So it's a huge epidemic. It's a huge outbreak. It's going to get bigger. It's going to get worse. But context is important. And our ability to protect our frontline medical personnel should be critical here. If we can't take care of sick people, it only gets worse.
We received a question. Can you speak to how long a positive case could possibly transmit the virus?
We're not culturing the virus. We're doing PCR. And when we detect that nucleic acid, we don't know if it represents live virus or not. It's good for diagnosis. It appears as if transmission stops as a patient recovers, which is usually within a week to 10, 14 days. And I think that's probably correct for this virus, and it was certainly true for both SARS and the MERS coronavirus. So I suspect people might be infectious for as long as a couple of weeks, but that is not a number that's been nailed down by anybody. You need to be very cautious when you're listening to people talk about positive tests. We are not culturing the virus. We are detecting it's got 29,000 nucleotides in its helix. The RNA has 29, almost 30,000 nucleotides, and we're amplifying 20. So 1/1000th of the genome that we're amplifying to say this person is a case. Whether that represents infectious virus is, and how much of it is infectious virus, how long infectious virus lasts, nobody knows. So we're going off of precedent and early epidemiology that people are probably no longer infectious after they recover, almost certainly. And we have 2 related viruses that have behaved that way, and I think that's the case. Bharat, have you read anything more definitive than that?
Nothing
I-
definite.
It's maddening that there's so much we don't know, but remember, it looks that way because we now, compared to 20 years ago, can figure out what's happening so much faster. They recognized something was going on in China at the end of December, and we had the virus in our hands within a week. Once everybody admitted there was something going on, the virus was isolated and sequenced within a week. It took a couple of months for SARS, is my recollection. A couple of months. So time is compressed by technology.
So
Yeah.
if somebody goes to the doctor now and has symptoms, what's going to be happening with testing?
Well, first, they're not going to go to the doctor unless they call ahead. They're not going to go to the emergency room unless they call ahead. They're not going to go to the urgent care unless they call ahead, so that they will know that somebody with a cough is coming in, and they can appropriately put that person alone in a room somewhere where they're not going to expose anybody else. 3.8% of, there's a website called Flu Now. Do you do it? It comes to me every week. And every week you tell them whether you got symptoms. 4% of the U.S. population this morning had symptoms of flu. 4%. There's a lot more flu than this stuff. So calling ahead when you're sick is always a good idea. The emergency room, if it's an emergency, it's an emergency. But otherwise, you need to let people know. So that's number one. So you don't have people coughing on other people sitting in waiting rooms. As testing expands in the U.S., what it's going to boil down to over the next week is if you're worried well, you'll probably be able to access testing. It's been a little slow rolling it out, but commercial labs are getting the test. All but 1 or 2 state labs have the test up and running now. And so progressively the requirements for who gets tested are being relaxed.
So you call ahead and then you go.
You call ahead. They're going to put you in a room by yourself. If you're coughing, they should probably put you in a mask if there are any left. And take a history and figure out what your risk is. And the CDC has very nice algorithms for moving forward in the evaluation. It's very simple stuff you can access at the CDC website.
So the health community here now is fully well aware and able to diagnose at this point.
Well, probably all except Dr. Matwani. He's been no. Yeah, I think so. I never say.
That wasn't the case 3 weeks ago.
Well, 3 weeks ago there was almost nothing in the United States.
Right.
The ironic thing about this is we should be doing this every year with everybody who's coughing, particularly during the influenza season. My approach to this doesn't change because it's SARS-CoV versus influenza versus whatever. It just doesn't. This is, as I said, good manners. Don't expose the people around you, whether it's flu or this. So the public needs to do what they should be doing all the time. The hospitals are going to behave a little bit differently because the mortality rate looks higher. Clinical docs and clinics and whatnot will behave a little differently because the severity, if you get infected, appears to be modestly, at least modestly higher than seasonal influenza. But in terms of the general public, it's good manners.
I just want to say, I want to clarify, when you say we can diagnose, we can test with the help of the health department. So we can test only those patients right now if the health department agrees with us that this is a suspect. Otherwise, we cannot.
Those requirements are being successively relaxed. Quest and LabCorp, I think they have the test.
Starting today.
It's starting today. So it's available commercially, and depending on supplies, that means that virtually anybody very soon will be able to get tested. Certainly anybody that's sick should be able to get tested now. That shouldn't be an issue. Do we need to test everybody with a runny nose in Scott County or Rock Island County? I don't think so, because we do not have sustained community transmission. We do not have any in Scott and Rock Island County that we're aware of. How do you expand and expand? When do you make the statement that there's sustained transmission? It's a public health function that we talk to the state talks to us, and we agree when we have evidence. And we're being very conservative. We're going to err on the side of being more aggressive as the test is rolled out.
So as the weeks go on, what symptoms should we look for, especially if you have, underlying health conditions?
Cough, fever, bad cold with fever, respiratory symptoms and fever. That's the primary thing. Again, lots of really nice, very simply written documentation at CDC, both state health departments. And I happen to like the WHO site because I think they're extraordinarily real-world based. But any of those websites, loaded.
So I'm sneezing for 2 days. It's my allergies.
Maybe or maybe not. At this point, you shouldn't be out exposing people. That's a sneeze, by the way. That's not a cough.
Yes.
Disposable tissues, that sort of thing.
How bad is influenza A this year?
Well, there's 16 million cases and between 10 and 20,000 deaths in the U.S. since the last time I looked, which was a week ago.
Are there any suggestions, recommendations when it comes to people's travel plans, whether it's simply I'm driving to Chicago or I'm flying across another country?
Well, my daughter lives in Munich and was on her way to northern Italy, and I said, you really shouldn't do that. And the next picture I got of her was on her skis in Italy. So, but, she's a kid, so there you have it. So read the travel notices at CDC. There's level 1, level 2, level 3. Level 2 basically says there's sustained community transmission. I would not go to a level 2 country at this point. I would not do that. The level 2 countries are, maybe it's, the level 2 and 3 are Italy, Iran, China, and South Korea. And I can't remember which one's still 2. Japan is 2. The others are 3s, I think, now. I would not go there unless I absolutely had to. Absolutely had to. To attend my father's funeral, maybe. To go to a wedding? No. I mean, don't go where there is sustained community spread. Number 1, you put yourself at risk. Number 2, depending on how things evolve over short periods of time, you may be in quarantine for 2 weeks after you come back. So pay attention. The CDC website, I might have minor disagreements with their wording, but I think level 2, level 3, don't do it. Oh, and I wouldn't probably get on a cruise ship right now. Although I hear you can get some good prices.
So if somebody says to themselves, I don't want to go to Chicago, I've heard the coronavirus is there, is that a valid fear?
No, I don't think so. There have been 6 cases since the first one. It's a month since the first case in Chicago. No sustained community spread. Would I go to Chicago to go to a Bulls game? Well, the Bulls are no fun to watch, so no. I wouldn't hesitate to go to Chicago. I wouldn't hesitate. Would I go to Seattle right now? Probably not. Let things settle out over the next couple of weeks. There's a lot of transmission occurring in Seattle. I think the people in South Florida are a little bit hacked that the State Department and other branches of the federal government have dueling messages about whether you should get on a cruise ship or not. Norovirus is bad enough. I think this is worse. So I probably wouldn't take a cruise, and I would not go to a level 2 or 3 travel alert country.
For people like you mentioned who can't afford to stay home from work, what do you say to them or their bosses?
Well, bosses are bosses. If somebody comes in sniffling and coughing, they need to be sent home. I'll just tell you that at the blood center, we have very clear, concise paid time off and sick leave rules. But we're convening the executive team and saying, do we need to suspend these rules and for the duration of the uncertainty with this virus, give people additional sick leave? And we're having that discussion because you don't want to incentivize people to come to work sick. And, will it cost the blood center something if we have to change the rules? Yes. So what? I mean, this is a public health issue. Yeah.
Can you talk about hand sanitizer? Is it better than washing your hands? Is it different? Worse?
Nothing's better than washing your hands under hot water with soap for 20 seconds. But hand sanitizers work. I ran out at home over the weekend, and I had to use Jack Daniels. It's only 40% alcohol. We prefer 60%. Yeah.
You've got a group of media here today.
I have a message for you.
And that's my question. What would you say to us?
Well,
We want to inform the public, but we don't want to create a panic.
Under the circumstances where we're operating now, you are public health officers, and you have an affirmative responsibility to ignore the BS and report the best opinions of the experts. And you need not to sensationalize this. There are a series of things that we're asking people to do. That needs to be the message. You can report the numbers from the Hopkins website or wherever you want, but if it bleeds, it leads, needs to be on the back shelf until we know where this is going. And I feel very strongly that way, that you are no longer just the media. You are public health officers, and you have a responsibility to the communities and the people that are listening to and reading what you're putting out there to be accurate. Both health departments, the state health departments, the CDC, are there to help you. There is such a thing as expertise. There are people who know more than other people, and that's who you need to be paying attention to. If you don't like me, find Matwani or Dr. Harb or Lisa, probably. She's the one I would listen to. I worked at Genesis all those years. I don't know the Unity Point people. I'm sure they're wonderful.
Angel knows her stuff too.
Yeah, Angel knows her stuff, Lisa says. But there is an enormous amount of expertise in the community, exclusive of the docs. And take advantage of it, and don't print and run stuff because it sounds juicy. Misinformation kills people. That's all I have to say, and I didn't mean to dominate things, but Matwani wants to talk.
No, you sit.
Stand up. I thought you wanted to say something.
No.
Do you guys from the hospital want to talk about what preparations the hospitals have taken?
Lisa, go ahead.
And please tell us your names and your titles.
Sure.
We know Dr. Katz. And he did tell us who he was.
I did?
He did. Somebody did.
I think Nita did, yeah. Good morning. I'm Lisa Caffrey. I'm Infection Prevention Coordinator at Genesis Health System. And we have been preparing for this since December, since it first came out. We started pulling out our pandemic plans and working with our public health partners to make sure that we were addressing the things that needed to be addressed in the hospital setting. We've looked at things such as our PPE supply, personal protective equipment supply. Those are the masks that Dr. Katz was referring to. Looking at, how do we handle visitors? And we have lots of people who come to both of our facilities all the time. How are we going to handle that situation? Will there be any other supply shortages that we need to address? And so we've been working on this for the last 6 weeks. That's all I've done for the last 6 weeks. And we'll continue to work on it as it unfolds over the next several weeks. So we work collaboratively with both the hospitals. Angel and I work together all the time on things. Our public health partners, whether it's at the local public health level or the state health departments, we meet pretty much weekly and maybe even more often than that now going forward. So we've taken this very seriously and we'll continue to do that.
Do you have enough supplies?
Right now we're okay. But as Dr. Katz said, people are out running around buying or taking masks inappropriately. I think probably you've noticed that we had to take our masks out of our public kiosks because people wouldn't just take one, they were taking boxes of them. So we had to do that. They're available behind our counters. You just have to ask for it. We're doing telephone triage calls for patients who have appointments scheduled, or as Dr. Katz said, if you're coming in for an appointment, give us a call before you come in if you're sick so that we can make the appropriate arrangements. But right now we have our supplies and we're business as usual.
Thank you.
Mm-hmm. Any other questions for me? Oh, yes.
Yeah, can you talk about visitor policy? Have you changed at all?
Sure. Well, we did. I think Friday we sent out a joint press release that we're asking that. Let me scoot over here. So Angel can join me. So that we're asking that visitors be only 18 years of age and older. Only 2 adult visitors per person.
To really not come if you feel ill at all. Obviously, our patient and visitor and our employee safety is our most important concern right now. So if you do feel ill, postpone your visit until you have recovered.
Mm-hmm. And then if you do come to our facilities, wash your hands. We have hand sanitizer everywhere. Both of the organizations do. If you need a mask, that's fine. Just tell us, I need a mask. Keep your visits short. Try not to linger. Come in, do your visit, wash your hands, leave the facility. Don't hang out in the cafeteria and things like that. So we're just trying to be proactive. And this isn't just because of COVID. We are still seeing a lot of influenza in the community, so it's also protecting our patients and our staff from influenza, which is still pretty prevalent in the area right now.
Still a big concern, and this is something we do every couple of years when there is a large influenza outbreak or the influenza is sustained over time. These restrictions or recommendations are nothing new at this time of year.
Yep, we put these out. We did it, probably October, November of last year. We just brought it back and put COVID in for the spring. So I think, I don't know what will happen over time. We'll just have to see how this all unfolds. There could be further restrictions, but right now this is what we're going to do. Do you want to talk about Unity Point?
Sure. So I'm Angel Mueller, Director of Quality and Infection Prevention at Unity Point Health Trinity. And we are doing very much the same thing that Lisa mentioned as well. We pulled out our 2009 pandemic influenza plan that we had developed at that time for H1N1 and just updated it according to what we needed to do for COVID-19. We have our protocols in place to identify potential patients that are at risk, who to inform, such as our health department partners, should we need to call them and figure out any next steps. And then our healthcare workers are trained on exactly what to do to isolate any potential patients to make sure that our patients are safe and our healthcare workers are safe as well. We've had similar concerns about masks being taken from our kiosks. So again, we have pulled those behind our desks, working at conserving those. So our healthcare workers do have those, but they are available should a patient or visitor need them. And again, our facilities are used to caring for patients with communicable diseases. So, it's really the same practices that we have in place for influenza and other infections that we've employed for COVID-19 as well right now.
Just talk just quickly about masks. We've talked a lot about masks, and this is one thing that Angel and I have noticed a lot. We talk a lot about masks, and we see a lot of people wearing their masks, but they don't have them on correctly.
Yeah.
They're either just covering their mouth or maybe just covering their nose. The mask does not work unless you cover the mouth and nose, and there's a little metal bar in there, and you pinch that over your nose. That's the only way you're going to get any kind of protection, but really the mask doesn't, it just keeps those big chunks from coming out all over everybody else. So the other thing you need to, you taught me that a long time ago, Dr. Katz.
God, 30 years?
Oh, yeah, yeah. The other thing, remember the front of that mask is contaminated. So when they're messing with their mask and then they rub their eyes, whatever's on the front of that mask is now in their eyes. So that's why the hand washing is really the most important thing you can do in whether it's COVID-19 or the flu or the common cold. That's how it's all spread.
And I don't think you'll have a conversation with either Lisa or I where we will not mention hand hygiene. So it's definitely the same now as with any other illness or any other situation. Hand hygiene is really the most important thing we can do to prevent the spread of infectious diseases.
Would you say masks are better for preventing someone who is sick from spreading it?
Yes.
Yes.
Source control, that's important to mask somebody who may be sick. We want to contain that, isolate any of those, the droplets left now, but
The droplets are
isolate those
But there are some
droplets.
people who would just want to wear it because they're not sick and they don't want to get sick.
Right, but they're not wearing full PPE, so that also includes goggles. I mean, the virus can enter any open sore,
Any
whatever,
mucosal surface.
and so the mask is only covering a small portion of their body, so it's really not protecting them like people think.
Right.
Because it's also not an airborne thing that they're inhaling; it's droplet, right? So
Right.
it's different.
And if you're not washing your hands and you're still touching your face, you could still become infected.
Yeah, it's giving them a false sense of security and put them at risk.
And it is taking the masks away from our healthcare workers who really do need to use those to protect themselves and our rest of our patients so that we can continue to provide care to our communities.
It's a statistical argument. A healthcare worker is very, very likely to come into contact with somebody hocking up all that stuff. Out in the general public, you're not, so save it for where it's likely. If it has great benefit, save it for where those critical people are working.
Even if you go into Walmart, you will agree that when somebody just coughs, you just pass by, you're still not at risk as compared to healthcare workers. So there's no point in wearing masks.
I don't think people understand that.
Right.
You are correct.
It would be a great opportunity for reporting.
And one of the things I want to add that Dr. Katz says, call ahead before you comment. But at the same time, if you get a call from a facility saying that, hey, are you having this symptom before your appointment? Don't panic. There's no cases in quantity yet. We are just proactive in asking that question up front rather than somebody coming in.
Yeah.
So
Yeah.
I just want to stress that. If you get a call from somebody, get a call from
I put a quick star by that on my notes.
Yeah.
Call first.
Oh,
Yeah.
it's huge.
Yeah.
It's just simple triage. So instead of sitting in the waiting room for 20 minutes and coughing, you take that person at the urgent care center straight into a room and close the door.
And be patient
just-
with us because you may get multiple phone calls. Just be patient with us. We're trying to protect our healthcare workers and our patients. So if you get 2 or 3 phone calls, we're just trying to be really cautious is all. Anything else? Anybody else need to? I'm stuck to the.
I'm just gonna close out.
Yeah, I wish it was more high-tech and we could sound smart. But for the general public, it's pretty simple stuff.
So again, thank you all for coming today. Updates will continue to be posted to both Rock Island and Scott County Health Department websites, as well as our respective Facebook and Twitter sites. We would like to remind everybody again to follow the 3 C's, which is clean, wash your hands often with soap for at least 20 seconds, Use hand sanitizer in between. Cover your coughs and sneezes with your elbow or tissues, as we've said many times already today. And stay home when you're sick. Avoid contact with the ill persons whenever possible. Okay, I think that concludes the press conference. And again, thank you all for coming.
We'll see how they